Okay, so we are going to go over a little bit about consent, informed consent specifically, but we're going to give a little background of kind of where it came from and how it all started, which I kind of feel like we've covered before. But make sure you read your notes because I took most of this information from your notes. But um, one thing you got to remember about informed consent is a lot of times we think we give conformed consent, but are they informed? So that can be really kind of a difficult thing when we're looking at this. So the benefits depend on the individual's goals and values. So one person may have something where feel like this is the treatment plan and they think they're being informed, but their goal may be different than someone else. And I really like these two examples that were given. So imagine that Greg suffers from a condition that causes him to be in a severe and constant pain. If his primary value is to be pain-free, he may value being prescribed strong painkillers, even if they inhibit his ability to carry out everyday tasks, including his job. So that might be Greg's goals and values. Like he wants to, I don't care about my job, I don't care, I just don't want to feel any pain. Okay? Compared to Lisa here, who suffers from the same painful condition as Greg, but her primary value is to continue to perform well at her job, then unlike Greg, she may value being prescribed a lower dosage of painkiller that allow her to remain lucid at work. So understanding what an individual's goals and values is going to make a difference in the treatment plan that you are moving forward with and how that informed consent is. So that, like, if you tell Greg that, or Lisa, that we're going to give you these strong painkillers because you're here because you're in pain, so we want to make you pain free, that's your values. But if you don't tell her, well, they're going to make you kind of drowsy and you're not going to be able to think very clearly at work and whatever, and she take these drugs, she wasn't technically informed. So she's consenting to a treatment that she was unaware of the full treatment. So that's kind of what we got to keep in mind when we're talking about informed consent and looking at it according to ethics. So autonomy versus beneficence. Values and goals are different for each person. Each patient has a different, like mine's going to be different than yours and yours are going to be different than mine. So autonomy may be more important to some patients over what a healthcare professional may view as implementing beneficence. So a healthcare worker is probably thinking, well, I want to do what is good for you and makes you better, do the least amount of harm, yada, yada, yada. But the patient may want to have some autonomy in that and make a decision like, yeah, I want to be pain-free, but I don't want to not be able to function like a human being. So that can be a really hard thing to handle. So informed consent is a tool that we use to allow patients the practice of autonomy. So we inform them like, this is the drug we're going to give you and this is what's going to happen. And Lisa's going to say, no, I don't want that. I would prefer to have something less potent, have a little bit of pain because I need to function at work. So that's where the autonomy comes in, and that's where informed consent is. But being able to inform them properly is super important. So this is something I want you to keep in mind when you're going through this PowerPoint. So you can copy these down or look at them or open them up on your Canvas course, but how much information is enough information? Who should decide how much information should be provided? The physician, the medical community, the legal team? Is it sufficient to merely hand someone a packet of information, or does a medical provider need to meet the patient to discuss that? That's kind of like even it makes me think of the pharmacy. Like when I'm given a new drug, the pharmacist always comes out and gives me a consultation on it. Even though I probably already know about the drug, I still respect the idea that that is part of their job. That's informing them on how to take the medication properly. Maybe there's something I don't know. So if a patient signs a consent form without reading it, is the patient really providing informed consent? And does it matter, given the patient also has the right to remain uninformed if they wish? Something to think about. Even if a form is signed, can we ever really know that a physician has disclosed all the necessary information to the patient? A lot of times we're not in the room. We don't know what he told them. Are there differences between our reasons for valuing informed consent and the way in which informed consent is actually obtained in practice? And or to ask this another way, does obtaining informed consent as commonly practiced actually meet the ethical ideas of why we think informed consent is so important in medicine? So I think these are some really good questions to think about. So the Nuremberg Code, we mentioned this last class. The Nuremberg Code was a trial that went back to 1946. It was American military tribunal opened criminal proceedings against 23 German physicians that did war crimes against Holocaust victims. So several German physicians argued when they were being prosecuted, this was their argument, that their experimentation didn't differ much from experiments conducted before the war by German and American scientists. So that was their argument, like, oh, they've done it before, ours weren't any different, so why should we be accused of war crime, is what they were saying. And there's no international law or informal statement differentiating between what is legal and illegal in human experimentation. So it really became hard to accuse them of these war crimes when there was nothing in law to do that. But what they did was 100% inhumane. I think I have a video in here to show you. So 2 American physicians, Dr. Ivy and Dr. Alexander, found this deeply concerning, that they were arguing these like, there's no law, what is legal, what isn't illegal, but they're doing these horrible things to human beings. So on August 9th, 1947, the trial verdict reiterated these points and entitled it Permissible Medical Experimentation, now known as the Nuremberg Code. So it started as that, now it's the Nuremberg Code. And this is the code. So to voluntary consent, the voluntary consent of a human subject is absolutely essential. They have to consent that they are involved in this experiment. The experiment should be such as to yield fruitful results for the good of society and procurable by other methods and means of student, and no random or unnecessary in nature. If you look at some of the experimentation that they did on the Holocaust victims, I don't really know what they're trying to figure out except to just see how a human body would respond in this situation. One of them, they put him in a chamber and pressurized it and changed the altitude of the room to 47,000 feet. And the individual went into convulsions and his lungs were collapsing on him. I mean, that's like outer space. There's no oxygen in there. The person couldn't breathe, and they just sat and watched it because they wanted to know how the body would respond to it. What was necessary in nature for that? That was just a random experiment. The experiment should be so designed and based on the results of animal experimentation and the knowledge of natural history of disease and other problems under the study that the anticipated results will justify the performance of the experiment. Basically, you can't just, there has to be a reason for you to think that this is going to happen. You can't just do it. The experiment should be conducted to avoid all unnecessary physical and mental suffering and injury. This one is shocking to me. No experiment should be conducted where there is a prior reason to believe that death or disabling injury will occur, except perhaps in those experiments their experimental physician also serves as a subject. So if they think there's a possibility of death or disabling, then the physician has to participate, which, okay, that's one way. There's 10 Nuremberg Code that they wrote. 6, the degree of risk to be taken should never exceed the determined by humanitarians. Importance of the problem to be solved. Proper preparation should be made. The experiment should be conducted only by scientifically qualified individuals. And then during the course of experiment, the human subject should be at liberty to bring the experiment to an end. So they should be able to leave and quit. And then during the course of experiment, the scientists in charge must be prepared to terminate the experimentation if they feel like it's causing harm or injury. Okay, so these are the Nuremberg codes. So that's where really informed consent came from. This is where med law and ethics kind of developed, was from the Nuremberg codes. There are a few other things out there that kind of created the medical law and ethics that we see today. The Declaration of Helsinki, which was created in 1964 by the World Medical Association. There was 17 years after the Nuremberg Code, which was 1947. The World Medical Association is an international representation of physicians, researchers, dentists, and more, and no legal authority, only ethical guidelines. So it's just ethical guidelines that they put out there. They have no legal, they don't say, because if you do this, this will happen, you're going to go to jail. It's just guidelines. And it's influenced by many governing bodies, and these are some of them that are influenced by these ethical guidelines, which is the Declaration of Helsinki. And then the Belmont Report, which is July of 1974, is the National Research Act, was signed into law. And this was basically a law that said, basically took the Nuremberg Code and put it into law. So now it created the National Commission of Protection of Human Subjects of Biomedical and Behavioral Research. So now we have this code. Now it's officially law. It took from 1947, when we decided that these Nuremberg codes came about and said these are so bad, to 1974 before it was actually put into law. Because the Declaration of Helsinki was no law, it was just ethical guidelines. So this is when informed consent became law, which is kind of crazy when you think about that. So informed consent, one thing you got to keep in mind, and we've talked about this already, is who can give informed consent? Are they capable of making an autonomous decision? Are they adult of mind, cognitively, mentally, physically? Can they make a decision? And if they can, then they can give themselves informed consent. Diminished ability of making decision would be considered children, cognitive impairment, mentally disabled. They may have diminished ability to make it, but rarely are patients actually incompetent. So I think this was brought up in our class last week when somebody was talking about, well, kids can say no. Yes, you're right. Children can say no. There are some children that will say no to shots and no to venipuncture, and we have to respect that. Like, if they don't want it done, they're not giving you consent. They're telling you no, and you can't force them to do it. So there is a point where you got to keep that in mind, that they have diminished ability, but it's not like they're incompetent. Now, an infant would be incompetent because they can't communicate. So that is where it becomes hard. But it's rare for a patient to be fully incompetent. Maybe somebody who's at end stage Alzheimer's or dementia or something like that might be incompetent. But those are some things you got to think about when you're looking at informed consent. Oh, sorry guys. I don't know if I can get rid of those boxes. Anyway, so that's going to drive me crazy. I got to remove them. There we go. There we go. So informed consent can revolve around all these types of things. When you're giving informed consent, you have to give the treatment, the nature of the treatment, what is expectations, alternative care, is there any other options, the benefit of the treatment, the risks of the treatment, and then you allow them to have questions. So this is kind of a good little image for you guys to look at to get an idea of how are we really informing the individual or the patient of the procedure or treatment or whatever it may be. And all of these pieces need to fall into that. So there's 5 elements of informed consent, kind of like that image: disclosure, understanding. You need to make sure they understand it. You can't just give them an informed consent and say, okay, sign this. They need to understand it. Voluntary, competency, and consent. Define the following. Informed consent is written, something in writing. Implied may mean nodding or, putting their arm out on a venipuncture or something like that. Also, I think implied consent can come into play like an emergency situation. So like I said, emergency situations where obtaining like a verbal or written consent is not feasible. Sometimes the healthcare provider may rely on implied consent for life-saving reasons. That would be implied consent. And then express consent is a clear, specific, usually obtained through verbal communication. So it's commonly used in non-emergency situations where patients have the time and capacity to provide like an agreement. So I think express consent would be more like, yes, you can draw my blood. So informed consent is typically required for surgery, medical procedures, treatments, and participation in research studies. And then you have your mature minors and your emancipated minors. A mature minor is a term used to describe an individual who, despite being underage, that is deemed that they're mature enough to make that information. So sometimes, like at the age of 16, they can start making. They're considered mature minor, and they can make that decision. Whether the minor is mature often includes the minor's ability to understand the nature and consequence of the medical procedure. So there's that. And then emancipated typically requires a minor to demonstrate financial independence. So I'm not sure if you've ever heard of a minor emancipating from their parents, but basically they're taken away. They're basically going out on their own under the age of 18. And there's actually some legal documentation that you have to do that. And then finally, you guys are familiar with advanced directives and living wills, but that's just when a patient is incapacitated and unable to provide consent. The healthcare provider may refer to the individual's advanced directive to guide medical decisions. So if you ever want, if you're getting older or, and you want an advanced directive, you want to make sure you give it to a child or one of your children, basically to help you make those decisions, just in case you get into a situation where you can't make them for yourself. So whoever has your best decision at heart. So that is the lecture. There is, let me see. Yes, there are a couple videos in the chapter called Informed Consent and Patient Capacity that I really want you to watch. I'm not going to put them here on this video, but it goes through informed consent and it gives some really good scenarios. So I want you to watch those. There's 3 of them in there and they're pretty short. And then there is, if you click on the Nuremberg Code, it'll open up, there is a video that talks about the story, the example I gave you of them how they treated the Holocaust victims. And if you want to watch that, you can watch that as well. And that is underneath the history of informed consent page. So you can read about that. So that's all I have for you guys today, and we will see you next time.